superior oblique. So a classic sign will be an intorsion sign if we're giving a retrobulbar block, because the trochlear nerve would not be blocked, right? And it shows the site of the peribulbar anesthesia, which is at the junction of the medial 2/3 and the lateral 1/3 on the diagram on the left, and then the superior block, which is given at the junction of the medial 1/3 and the lateral 2/3. Right. Right. Now the medial conal is generally used as an adjunct to peribulbar anesthesia. We also inject this in the peribulbar space, and we inject this at the medial junction of the lids, nasal to the lacrimal caruncle. Depth, the needle hub reaches the level of the iris. The bevel should face the orbit wall. One important structure here is the wall of the ethmoid sinus, which is very thin, which is paper thin, so we should guard against entering into that sinus. And we advance backward in transverse plane and towards the middle orbital wall. We keep away from the globe. But at the same time, we got to be careful not to traumatize the ethmoid sinus. Well, this is a comparison of the difference between the two blocks. You can see a cone being drawn, and you can see that the peribulbar block is the anesthetic injected around the cone, but in a retrobulbar block, it is injected into the cone. Right. So what are the differences between the two? Peribulbar is safer. We are staying away from the globe. It's safer, but then the akinesia has a slower onset because it is spread out over more tissue. The volume of drug required to produce the same degree of akinesia and anesthesia is greater in a peribulbar block. There's more pressure because of the greater amount of drug that we inject. We may need more supplementary injections in a peribulbar block. It can cause ecchymosis, periorbital ecchymosis. This is because the anesthetic agent in a retrobulbar block is essentially present behind the cone, but in a peribulbar block it's present around. And going back to the diagram, the increased volume of the anesthetic can press on the orbital septum or can even come out. And I've noted, a swelling of the lids when I give a block. It does cause more periorbital ecchymosis as compared to retrobulbar block, and it can cause a high degree of conjunctival ecchymosis too. So, but these are the problems with the peribulbar block. But with the retrobulbar block, the biggest disadvantage is going to be one, that you're going to go much closer to the globe, so there's a high risk of globe perforation. Two, you're also going pretty close to the optic nerve, and if you're going to pierce it, you can, one, cause optic nerve trauma, you can cause optic neuritis, and two, you can also enter centrally if you inject into the meninges that cover the optic nerve, and that would cause central spread, and it can cause CNS depression. Right. So the toxicity related to the drug per se, not to the technique of anesthesia, but to the drug per se, the chemical. It causes CNS depression or CNS signs earlier than the cardiovascular system. So the central nervous system is affected before the cardiovascular system is concerned. So we've seen many of us do monitor the blood pressure, and we monitor the pulse rate when we're injecting. I'm not too sure how effective that's going to be. Probably a more reliable sign of toxicity would be circumotor paresthesia, seizures, because that is what is going to result first. It's going to first cause CNS excitation. So the patient might seize, he might convulse, he's going to have circumotor paresthesia, and then it's going to result in CNS depression. So it's a biphasic response to the drug. And we're going on to the cardiovascular system. It causes hypertension, bradycardia, arrhythmia, and arrest. So yes, well, if you're monitoring the patient, we should look for a drop in blood pressure and a drop in heart rate, right? Okay. Now, it can also cause systemic allergy. It can cause local tissue toxicity because of the drug, and the muscles and the nerves present will can act as a myotoxic and a neurotoxic agent, just the drug per se. But we are still here not referring to the technique or the mechanical effects of the anesthesia. We're talking about the inherent properties of the chemical of the drug. Now, we go on to the complications of the technique. So it can lead to globe perforation, it can lead to retrobulbar hemorrhage, systemic toxicity we've already described before, diplopia and ptosis are two of the rare signs which we do see with the anesthetic techniques. The signs of low perforation. But I think the most important point is extreme pain. The patient is going to feel a lot of pain. Okay, um, well, we can have a poor red reflex and hypertonia of the globe. Well, if you feel the globe might really feel um, very flail, or well, it can be very hypertonic, um, and can have a poor red reflex. But I think an important sign to look here is when we're advancing the needle, it's going to cause extreme pain to the patient. This is a fundus picture of the head, which shows a needle shrink injury. It's present in the macula, which means the patient's vision is almost gone. Mm. So retrobulbar hemorrhage. Right, it can either puncture a vein or an artery. So here's the concept of a compressive versus non-compressive. But I think this concept is pretty self-explanatory. Well, a vein is going to have less blood that is going to ooze out, so it's going to be a slow oozing out of the blood, and it's going to lead to a non-compressive hemorrhage, whereas an artery is going to cause a compressive hemorrhage. So what an artery does is it causes rapid and total vital swelling, proptosis, immobility, elevated intraocular pressure, and now the lids are going to be very difficult to separate. So that could be an important sign. Now, the minute you give an anesthetic, um, the tone of the lids is gone. You can just move the lids very freely if your block is good, and the patient has no voluntary control over the lids. But the lids can get really tight, and that's when you probably you've caused an RBH. You can have massive ecchymosis of the lids and of the conjunctiva, and you can also have impairment of globe vascular supply in rare cases. Um, Again, I used to always wonder why we give the ocular compressions. Was it to increase the spread of the anesthetic agent around the eyes so that the block comes faster? Was it to lower the intraocular pressure? But I don't remember where I read this, but I did read this in a place which said that the ocular compressions intermittent, not lasting more than 20 seconds, such that the vascular supply of the globe is not compromised, should be given as soon as the block is given to compress any bleeding vessel to act as a tamponade. So I think that is probably the most important function of somebody giving an ocular massage. So, well, you don't always have to um, look at giving a massage just to lower the IOP. It's also immediate because um, when we do advance the needle, we don't really know whether we're going to puncture a vessel. Anatomy determines effect. I'm quoting the line again because I think that's one of the most important statements in a block. And we never really know where a vein or an artery might lie, and we might just accidentally puncture it. So I think that is unavoidable. We might just puncture it, but what is avoidable is not stopping the bleeding. So I think the minute we give a block, it is important to give the compressions not lasting more than 20 seconds, such that no hemorrhage really um, advances to such an extent that it causes these signs that have been listed here. Special anatomical problems: myops, increased axial length, greater globe size. The sclera is more thin, so can be more easily punctured. So yes, we got it. So in a myope, especially when we see an IOL power calculation of less than 10, well, we know it's he's probably a high myope. So we got to stay as close to the orbital wall as possible. Try not to attempt anything retrobulbar or really peribulbar, even if it's going to cause you having to give more number of blocks or more anesthetic agent. We should stay away from the globe. Deep set eyes. Well, a few of the practical problems I faced is it is a little more difficult to give an anesthesia in a deep set eye, and also, well, while giving the anesthesia, we can actually help the surgery by causing a little bit of proptosis with the anesthetic agent, so we just get the eye out a little bit. Um, the age of the patient. How's the age of the patient important? Yes, the tissues are weaker. They tear more easily. Yes, so that's a point to remember. And hemangioma, or if probably present in the lids or something, we have to be careful because it can cause a lot of bleeding. So, now subtenous anesthesia. This diagram here shows what the Tenon's capsule, well, where it is. On the right, we see the conjunctiva has been raised, and then we see the Teneth capsule and the sclera. So it's space between the sclera and the Teneth capsule where we give the subtenous anesthesia. It's also called parabulbar anesthesia. Right, so is the technique of giving the anesthesia. We slowly lift the conjunctiva and we identify the subtenous space, and with the globe, with the bevel facing the globe, we we advance and we inject it into the subtenous space. Sounds very simple, isn't it? Right. Now, well, it can cause chemosis. Um, it can cause hemorrhage because we all know there are a lot of blood vessels present around there. It can damage the vortex veins, and that can cause a lot of hemorrhage. And this should be essentially avoided in a patient who is on anticoagulants. Right. Topical anesthesia. I think this is the most humane form of ophthalmic anesthesia, which is a non-invasive procedure essentially. It's available in many forms: drops, jellies. So we can use a lidocaine jelly. We can also use a tetracaine or paracaine jelly. What we can also do is in a cotton swab, that's a soft sponge. Um, we we can just put the drops in it and place that in the superior and the inferior fornix, and that slowly releases the anesthetic agent into the space. Thornton's concept. And the concept is that um, any anesthetic that is placed in the fornix slowly is going to diffuse into the peribulbar space. So it's going to be as effective as peribulbar anesthesia over some time. And we can also give, well, the topical anesthesia is not really going to cause that much of intraocular anesthesia because the ciliary ganglion is essentially inside the intracorneal space. So what is anesthetic might not really reach as far as the ciliary ganglion, so we might need to give an intracameral adjuvant. And moving on to the lidokinesia. Well, there are four kinds of lidochinesias. I wouldn't really elaborate much on these echinesias, just the site where these blocks are given. The first one, the farmland block, is mainly orbicularis well, orbicularis oculi akinesia, which we aim to achieve with this, with the farmland block. So where we first identify the lateral extent where the superior and the inferior orbital rim meet each other, and we advance with the needle and we inject in that space, and then we withdraw the needle back a little bit without coming under the skin, and we go into the upper eyelid and the lower eyelid and we inject the anesthetic agent in those areas. Well, the NADPAT LS is an anesthesia which is given along the inferior rim of the zygomatic bone, and at the point where the arrow starts is where we um, enter with the needle and we advance all the way through the top, and that's how we cause echinacea. The O'Brien anesthesia and the Atkinson anesthesia, they mainly paralyze the facial nerve at the point where it exits the cranial cavity. So, so that's where these two blocks are used. Now, the applications today, well, there are a wide number of surgeries where these blocks are used. Just to list a few of them, just to give us an overall idea of where these blocks can be used. It can be used in cataract extraction, iodine implantation, corneal transplantation, glaucoma filtration surgeries, most of the oculoplasty surgeries. Well, they would need the lid blocks, the facial nerve blocks as described in the previous slide. Strabismus repair, vitrectomy, refractive surgeries, mainly. The topical anesthesia would be good enough, and foreign body removal, again, the topical anesthesia would be good enough. Yes, thank you for your attention. Operate pain-free. Thanks. If you have references, if you would wish to read more about this,